forward in our IC. The next speaker is Dr. Nitin Kumar, and he will be taking you back to the basics and discussing the role of naming and meshing in uveitis case workup, outlining basic clinical workup and its relevance. Dr. Nitin, please.
So Dr. Nitin is a young enthusiast, uveitis specialist from AIMS Jammu, and he has an excellent training done at PGI Chandigarh.
Thank you,
and Shankar Netralaya, of course, he's a student of JB sir.
Yes, ma'am. Thank you so much. So, in the last session only, we had a very important discussion that there is no substitute to a good clinical history and examination, and most of the diagnosis can be made on the basis of history and examination only. So, I will be highlighting these in my this presentation. So, as ma'am has also told previously that history and examination can establish almost diagnosis in about 70%, 70 to 80% of the cases of uveitis. So what constitutes a basic uveitis workup is very important to be highlighted. So we have to pay a very stress on the history, review of systems, a good ocular examination, and we have to find out where the intraocular inflammation is exactly there in the eye. So we have to classify whether it is limited to anterior segment or posterior segment or the whole of the eye is involved, that is the pan-uveitis. And this should be followed by a very good systemic examination, and I will be talking about what is exactly naming, meshing. And in the previous talks you have just seen that there are so many diagnostic imaging modalities as well as tests are coming up, and the technology is evolving every day. So but again, why classify? It will be very if this we pay attention to this image, it will be easy to find a book which has been arranged in the library rather than this stack. So this is why we have to classify our patients of uveitis to find out the diagnosis. Previously it was thought that most of the diagnosis, most of the uveitis is idiopathic, but now we have come to know that there are so many diseases which will lead to intraocular inflammation. So coming to these two images, we can see that they have similar kind of presentation. Both have a hypopyon uveitis. So in these kind of situations, we will have to go back to our history and a good clinical examination. Why we should do naming and meshing in our basic uveitis case workup? There are numerous disease associations and varied etiologies. These can be infectious, non-infectious, as well as immune mediated. And different entities may have a similar clinical presentation, like which I have shown in the previous slide. And this can lead to diagnosis being very challenging, and also there can be some diseases in which there will be systemic involvement also, and others which will be limited to the eye only. So if we have to solve a problem, first we will have to define the problem. So this is where naming comes into the picture. And then when we have done naming, we will have to compare this with known etiologies, known patterns, to find out in which pattern our patient is fitting. How do we do meshing? So this is based upon the demographics of the patients, and then we have to ask about the severity, chronicity, establish the laterality of the disease, pathology of the disease, and again where the disease is located. We all know that certain kind of diseases will be common in a certain age group, like GI is more common in children, parasitic uveitis, HLA associated uveitis is more common in cases of adults, and in old patients there can be masquerades as well as this herpes zoster ophthalmicus. Similarly, certain diseases will be more commonly associated with a certain gender, like VKH is more common in females, autoimmune diseases are more common in females, and males they may have more of sympathetic ophthalmia due to the injuries to the eyes. Again, socioeconomic status will have an implication about the parasitic diseases. And again, these thing is also very important. So we again, if I highlight that based upon the symptoms, we can see which part of the eye is involved. Like pain and redness is more common in anterior uveitis, floaters will be more common in intermediate uveitis, and posterior uveitis can lead to decreased vision. Limited duration of the disease, whether it is less than 3 months, persistent, greater than 3 months, whether it has been an acute onset of the disease or this has been a chronic disease. Again, in cases of HLA-B27, the patient will be exactly knowing the day and the time when the disease started. So this is how we can just probe into the history and arrive at a case profile of the patient. Again, whether the disease was mild, moderate or severe, and what is the pathology, whether it is granulomatous or non-granulomatous. And we have to arrive at an etiology, whether it is infectious, non-infectious, there has been some history of trauma, or the patient belongs to extreme of the ages where masquerades are common. Anatomic classification is also very important. So these are some examples how we exactly do it. So we have to, just like this, the example is there, a 9-year-old white girl with moderately severe acute bilateral non-granulomatous hydrocyclitis with mild bilateral band-shaped keratopathy and occasional right pain. So this will lead us towards a diagnosis that this can be probably JIA. And similarly in other examples, like if we see a young white woman with mild chronic unilateral non-granulomatous kind of a uveitis with elevated IOP, cataract and heterochromia. So this will help us to just narrow down on our diagnosis. Again, then we have to compare those with the common uveitic entities and the signs and symptoms of those diseases, which are seen in this busy slide. So if there are some dendritic ulcers that are commonly seen in viral uveitis, so we will compare our case to what is already known. Like iris atrophy is more common in case of viral anterior uveitis. Again, focal retinitis, that may be in patients of Behçet's and SLE. And diffuse retinitis, which can be seen in acute retinal necrosis. So in some of these diseases, you don't need to do these fancy tests to get to a diagnosis. Only a good clinical history and examination will lead you to the diagnosis of the disease. So we'll come back to the pictures which I had shown you. So these are two cases with the hypopion anterior uveitis. Hypopion uveitis, sorry. So we don't know, without fundus examination we can not know whether it is anterior uveitis or whether it is involving the posterior segment also. So this is how we should do it. So if we see, this was a 23-year-old male, Asian, who had severe kind of this uveitis, although in this image that fibrin is retracting, but when he had initially presented, the whole anterior chamber was full of the fibrin. So this was a non-granulomatous, there were no KPs, and this was primarily involving the anterior segment. When we did a fundus examination for this patient, there was no involvement of the vitreous, neither there was any lesion in the retina. So again, when we did a review of the systems, the patient gave specific history of morning stiffness, and there was backache. So these will lead us to a diagnosis. And then only we have to do some specific tests. For when the patient had given this history, then we did a single test, HLA-B27, and advised for MRI. So this can help us to reduce the burden to the patient also, do specific imaging as well as systemic tests for these patients. And this one turned out to be Behçet's, because as a part of the clinical examination, we saw that if we can see, there was this hypopion was mobile, and the patient had history of oral and genital ulcers also. So history and a good clinical examination will lead us to diagnosis in most of our cases. Thank you so much.
Thank you, Dr. Nitin, for such a comprehensive presentation, which takes us back to the basics of uveitis. I would like to request our audience if they have any questions, because this is... Yes, ma'am.
This is about empirical treatment for suspected tuberculosis. Sometimes, we get cases which, it's a recurrent granulomatous uveitis maybe with a little bit of choroiditis, and it keeps coming back. And there's nothing on the test. We send them to the pulmonologist. They check for chest x-rays and it's negative. The MAN2 is positive, but then we we're all probably positive. And I'm not getting anything else. And nowadays, empirical treatment you can't just give without some data. So what do you do in these cases when you have a really strong suspicion, but you're not getting anything?
I'd request Manisha ma'am to please answer this query.
So, ma'am, that's a very valid question that you have raised. And most of our physicians don't understand that you can have ocular tuberculosis without any evidence of systemic TB, and that is where the problem is. Because we have a very strong suspicion, but we send them, they say there's no evidence of systemic TB. Now here comes, I used to face the same problem when I started practicing. The physician has to work very closely with you and rely on your findings and clinical suspicion. And nowadays, the physicians, they know that you can make a diagnosis of ocular tuberculosis. If you are going to be sending to a person who's a pulmonologist, not seeing patients very frequently of ocular TB, he's not going to believe you. But like we are working very much closely with the physician, he knows now that we are able to detect. When we tell them that please give a trial of ATT, they rely on our findings and start on an ATT trial for 2 months. And once we get a good response, we then give a full course. But that is the only solution. There's no other way out.
So empirical treatment even without positive A is now.
Absolutely, absolutely, yes.
Thank you.
Thank you.